Hi everyone, my name's Paul. I'm one of the Cardiology Advanced trainees at Westmead Hospital. I've been asked to present a case today on sarcoidosis. I've actually got two cases to present, trying to highlight really the varying ways that sarcoidosis can present, particularly cardiac sarcoid. So I'll move on to the first case. It's a 63-year-old lady who had quite an unremarkable list of background medical history, really. She had a long-standing left bundle branch block on her ECG and an echo dating back over a few years that showed just mildly impaired systolic function and a mild to moderate LVH. She more recently presented with dizziness and was found to have progressed in her conduction system disease to 2-to-1 heart block, causing her symptomatic bradycardia. Her echo really again showed really only mild to moderate LVH, which did have some suggestion of regional variation in the degree of LVH and near normal systolic function. No real convincing regional wall motion abnormalities, although it was a bit more difficult to appreciate whether there were some septal abnormalities in the context of her left bundle branch block. As you might expect, her tissue velocity of her mitral annulus E primes was significantly reduced. And her strain was reduced at -13%, a global longitudinal strain, with really a patchy reduction, but particularly her basal septal regions were reduced. She went on to have a coronary angiogram, which showed minor coronary artery disease, and her cardiac MR, which unfortunately I don't have pictures of, but really showed quite a mixed bag of some areas of confluent late gadolinium enhancement at the basal LV, other areas subepicardial and mid-wall pattern of late gad enhancement, but no edema. This was reported as suggestive of sarcoidosis, and she underwent insertion of a CRT-D system. In light of the absence of any edema suggesting active disease, she was not started on any immunosuppression or steroids. Contrasting that case with another case, which is a 44-year-old gentleman, previously well and fit and active man, who presented to hospital with conscious VT earlier this year. His echo was quite different. He had severe LV impairment with an akinetic apex and the presence of an LV thrombus on his presentation. He had a coronary angiogram which showed normal coronaries. He underwent a PET scan, which is shown just representative here, which showed some areas of mildly increased uptake on the FDG PET, with other areas showing significant reduction of perfusion imaging, particularly around his apex, which was suggestive of a mix of some active disease, but really quite advanced sarcoidosis, with other areas, as I mentioned, of reduced perfusion, suggestive of scar. Similarly, his cardiac MR showed areas of extensive circumferential late gadolinium enhancement around the apex and other areas of mid-epicardial and transmural late gadolinium. Similarly, he underwent an AICD after uptitration of antiarrhythmic medications and was commenced on high-dose steroids. Unfortunately, he represented to hospital 4 to 5 months later with VT storm, actually undergoing about 80 shocks from his device with conscious VT. This required intubation in the end in ICU, as well as amiodarone. A repeat PET at the time showed ongoing inflammation, and so he was restarted on high-dose prednisone as well as infliximab, and he was actually referred to our centre for consideration of VT ablation. In the meantime, he's again represented with more shocks from his device, unfortunately. I've got some representative echoes here, a more recent scan of his. So again, he does have quite more impressive reduction of his systolic function with primarily an akinetic apex. And again, possibly some regionality in his degree of LVH, which is not severe LVH. And really quite an impressive abnormal regional wall motion abnormalities with his akinetic apex, which matches the PET and the MRI findings of no uptake, but really just scar in that area. And again, his global longitudinal strain was very much reduced at -6.5, and patchy reduction really in his case reflecting his akinetic apex. And again, as you'd expect, very low E prime values. So just after those cases, I thought I'd talk a little bit about sarcoidosis and cardiac sarcoid. I know there are a few talks coming up going more specifically about echocardiography and MRI in sarcoid, so I've somewhat skimmed over that. But I hope those two cases in their brevity show that really it's a very varying presentation that can be from the same disease. And sarcoidosis is a very difficult disease to diagnose and manage. It's a multi-organ inflammatory disorder, which really is essentially of unclear cause. It's defined by the formation of caseating granuloma throughout the body, most often in lung and lymph node tissue, but really it can involve any organ, and the heart is no exception. It's a rare disease, varying reports of 5 to 40 cases per 100,000 people. And the image there actually shows an endomyocardial biopsy with the arrows showing the characteristic caseating granuloma seen. Cardiac sarcoidosis is considered a reasonably rare occurrence in sarcoid, with clinical diagnosis of 2 to 5% of sarcoid cases. There are some more recent studies looking at both autopsy findings and imaging studies that suggest it may be far more common. Up to 1 in 4 patients with sarcoid may have cardiac involvement. As in other infiltrative disorders, the involvement of the heart significantly increases mortality in sarcoidosis. And really it can affect any part of the heart, including the pericardium, classically the atrial and ventricular myocardium, papillary muscles and valves. And there are even some case reports of vasculitis involving the coronary arteries. As I alluded to, it's a difficult diagnosis, which is often delayed. Cardiac biopsy has quite a low sensitivity, particularly when it's not guided by imaging, really due to the patchy nature of the disease. Clinically, it has a very non-specific and varied presentation, and really the imaging findings, particularly echo, reflect that too, where often we have quite non-specific findings. And in fact, there's some reports, some studies that suggest maybe only 25% of people with cardiac sarcoid have significant abnormalities on their echo. There are some diagnostic criteria. There's no real consensus, but the two commonly used ones or suggested ones are Japanese Society of Sarcoidosis from 2006, which really uses a distinction between histological diagnosis, where you have an endomyocardial biopsy, and a clinical diagnosis. Of note there are some criticisms that it still keeps a gallium scan in the major criteria, while something like a gadolinium enhanced imaging, CMR is minor criteria, which is probably somewhat out of date. I think gallium is quite, has its drawbacks and some limitations, as opposed to gadolinium imaging, which is a more up-to-date modality. Similarly, the Heart Rhythm Society is somewhat more up-to-date, although it's also 7 to 8 years old. And it's really a combination of both histological and clinical criteria. But really in practice, it's something to suspect if you have particularly a somewhat younger patient with unexplained AV block, plus or minus atrial ventricular arrhythmias, often the combination of both, unexplained systolic dysfunction, or unexplained sudden cardiac death. I've just got this slide here of PET imaging to really show the spectrum of disease that I mentioned in those two patients, illustrate that really spanning from active disease with quite marked increase on FDG PET, all the way through to scar with no real FDG uptake and reduced perfusion in corresponding areas, which is a less active, almost burnt out form of the disease. And the benefit of immunosuppression in those patients is quite a bit less or minimal. Very briefly on management, as I mentioned, the imaging not only helps diagnosis, it really guides management and prognosis. So the utility of immunosuppression is really guided by uptake on PET, as well as cardiac magnetic resonance, really seeing if there's any active disease versus just scar. Management is generally immunosuppression with high dose steroids, and then often addition of other factors such as infliximab. AICD insertion Obviously, one of the major concerns and causes of death in these patients is ventricular arrhythmias and sudden cardiac death. And prognosis is guided again by uptake of PET and the degree of late gadolinium scar on magnetic resonance imaging. So in summary, sarcoidosis in general is often referred to as a great mimicker and a real diagnostically difficult disease, and cardiac sarcoid is no different. You really do need a high index of suspicion to diagnose it, and it's a great example of an infiltrative disease where you really need multimodality imaging, not only to diagnose, but to manage these patients and sort out their prognosis. It's obviously an evolving area, particularly with strain imaging, which I haven't spoken about, which again, like many conditions, there is good evidence emerging that it can help guide prognosis. And of course, MRI is really growing in its use across all infiltrative diseases. Thank you.